Uh, Namaskar and hello, and a very warm welcome to all our viewers. Today, we are having an international faculty webinar, and we are indeed honored and pleased to announce the presence of Professor Michelle Chew. Michelle Chew is a very well-known figure in cardiovascular hemodynamics in intensive care. Ma'am is the academic chair and professor in anesthesiology, intensive care, and acute care at Linköping University Hospital, Sweden. She is chair-elect of the cardiodynamic section for the European Society of Intensive Care Medicine, ESICM, that is, and she is editor, British Journal of Anesthesia, and deputy editor-in-chief of European Journal of Anesthesiology, amongst many other things. Welcome, ma'am, and thank you very much. We are honored, really honored. And we also have with us Dr. ZAHER Ahmed. Sir is a senior clinical fellow at the prestigious Oxford University Hospitals, and he is a member of the ESSM Next Committee. Next Committee is a committee which has a gathering of prestigious young members of ESSM. Welcome, Dr. Ahmed Zaher. Very pleased to have you with us. Thank you very much. So we'll take all the questions in the end. So over to you, ma'am, and Dr. Ahmed.
Great. Thank you very much, Dr. Bansal. Dr. Zahir and I are absolutely thrilled to be here today. Thank you so very much for this kind invitation. And I hope we'll be able to give you some important, not advice, but share our thoughts on how to manage hemodynamic monitoring in ICU. So I will share with you my slides. And if you like, I can also give you a copy of these after the hospital. I have several conflicts of interest to declare with Edwards Life Sciences, AOP Health, and Philips Healthcare, not related to this lecture. Whether we should prioritize blood pressure or blood flow has been a topic of controversy for decades within the critical care community. And indeed, many of you will recognize this screen here on the top left corner of the slide, showing the pulse rate, saturation, and arterial blood pressure. This is a very standard monitoring screen in intensive care, but fewer of you will recognize this screen here on the bottom right-hand side of the screen, showing the stroke volume variation, the DP/DT, cardiac output, as well as this index, the hypotension prediction index, which we will not talk about today. So this screen will give you more advanced hemodynamic measurements, including the blood flow. When considering cardiovascular physiology at the bedside, we have two main hemodynamic treatment goals. Firstly, the optimization of perfusion pressure, and secondly, the optimization of oxygen delivery to the tissues. Recall that perfusion pressure is determined by the difference between mean arterial pressure and the outflow pressure, where the outflow pressure is simply taken as the CVP. So the CVP may be taken as a surrogate of the outflow pressure to organs, much in the same way as intracerebral pressure is taken as the outflow pressure in the brain. For tissue oxygen delivery is in turn determined by cardiac output and the arterial oxygen content in blood. And you will recall, of course, that cardiac output is determined by stroke volume and the heart rate. So from this diagram alone, you will see how mean arterial pressure and cardiac output are inextricably linked in order to provide homeostasis. It is important to remember that there is no normal value of cardiac output in the critically ill individual, because that level is determined by the body's metabolic requirements. So recall that oxygen delivery to tissue is controlled by the cardiac output as well as the arterial oxygen content in blood. And the arterial oxygen content in blood is determined by the hemoglobin as well as the saturation of oxygen in arterial blood. In contrast, the mean arterial pressure determines organ perfusion. Now, from a previous slide, I said that Organ perfusion is the difference between mean arterial pressure and the output pressure. And in the body, the mean arterial pressure minus the output pressure is approximated by the mean arterial pressure minus the CVP. The mean arterial pressure is in turn determined by the cardiac output multiplied by the total vascular resistance. So today we're going to break down the physiological principles of organ perfusion and blood flow. So recall that cardiac output is determined by the stroke volume, which in itself is determined by the preload, afterload, and contractility. Now, preload is simply the volume of blood in the ventricle at the end of diastole, so it's the same as end diastolic volume, which is difficult to measure, although you can measure it with ultrasound. And preload is also important because it is a reflection of the venous return, which is a quantity of blood flowing from the veins to the right atrium. And in the absence of intra-cardiac shunts or other important shunts, venous return is the same as cardiac output. And afterload is the force against which the ventricle must contract in order to open the aortic valve and to eject the blood into the systemic circulation, and that is determined by the vascular impedance of the aorta. Contractility is simply the degree of stretch of cardiomyocytes at the end of diastole, so it reflects the energy of contraction, and we're going to talk about each of these principles in the following slides. So how does cardiac output monitoring help me at the bedside? Recall that in the critically ill, there is no normal cardiac output value, and an adequate cardiac output is that which provides adequate oxygen delivery to the tissues. So cardiac output may be used to assess response to treatment, for example, a fluid infusion or an inotrope infusion, and cardiac output is also the gold standard for monitoring fluid responsiveness. So there may be several ways you may assess the adequacy of cardiac output. Of course, you may monitor trends in cardiac output, for example, increases or decreases in response to treatment. I've also said that cardiac output measurement is the gold standard for monitoring fluid responsiveness, and I will talk about it later. However, in order to assess the adequacy of cardiac output, we may use indices such as the SVO2 or the PaV-CO2 gap, also known as simply as the CO2 gap. The adequacy of cardiac output may be easily estimated by considering the PCO2 gap. So the PCO2 gap is the difference between the arterial and venous partial pressures of CO2 that you measure using your blood gases. An abnormal level is more than 6 millimeters of mercury, and it basically tells you about whether or not cardiac output is adequate to wash out carbon dioxide from the circulation. And in this paper by Professors Valle, Pinsky, and Sacconi, you will find excellent explanations about the PCO2 gap and how you may put it together with your other indices such as O2 extraction ratio, SCVO2, and lactate in order to have a better idea of what the circulation, of the performance of the circulation. So now I want to briefly talk about one of the three determinants of stroke volume. The first determinant is preload, and we know that preload is determined by venous return, and according to Guyton physiology, and it makes intuitive sense that venous return must be equal to cardiac output in the absence of significant shunts. So how do we assess preload? It is important to remember that preload is not the same as venous return because preload is also dependent on ventricular compliance. So in a ventricle that is non-compliant, the pressure will increase. So for the left side of the heart, this is measured as the pulmonary occlusion pressure. So you will need a pulmonary artery, a catheter to measure it, or you can make a qualitative estimate using echocardiography. For the right side of the heart, a non-compliant ventricle or a right side of the heart will be seen as an increase in CVP. However, preload may also be estimated by static volumetric measurements such as the global end-diastolic volume and the intrathoracic blood volume that you can only obtain using transpulmonary thermodilution. Of course, you can also do a clinical assessment looking for edema, a raised JVP, a lung ultrasound with B lines that will tell you that there is overload on the left side of the heart and the right side of the heart. You may also assess by ultrasound, by the CVP, and the appearance of the inferior vena cava. Preload is not synonymous with fluid responsiveness. So remember that fluid responsiveness is defined as an increase in cardiac output of more than 10 to 15% in response to a fluid challenge. However, if you do not want to give a fluid challenge, you may also do one of the many maneuvers that have been described in the literature, such as a passive leg raising, the N-expiratory occlusion test, the N-expiratory occlusion plus inspiratory occlusion test, a PEEP challenge, as well as a tidal volume challenge. And in this context, I want to particularly mention the tidal volume challenge because this is the one method that can be used to assess fluid responsiveness in the absence of a cardiac output monitor. So this method was pioneered by Professor Sheila Mayatra in India, and it involves, in mechanically ventilated patients, increasing the tidal volume from 6 to 8 milliliters per kilo over 1 minute. And then you watch for a change in the pulse pressure variation. An absolute change of more than 2.5% suggests that the patient is fluid responsive. Fluid responsiveness tests are important because there are very real risks of fluid accumulation and harm if fluids are given when they are not needed or if the cardiac output is not increased. So the way you would assess it is by increased feeling pressures, such as with the pulmonary artery occlusion pressure or the CVP. You may assess for intra-abdominal hypertension. You may use your PICO or the transpulmonary thermodilution to measure extravascular lung water or the pulmonary vascular permeability index. You may also do a lung ultrasound showing multiple B lines or venous congestion within the splanchnic circulation, or you may simply look for total body edema and increasing daily fluid balance or body weights. So unfortunately, the risk of fluid administration is beyond the scope of this lecture. However, everything that you need to know about fluid accumulation syndrome and deresuscitation can be found in this excellent paper by Professors Malbrain, Martin, and Osterman. So I would refer you to this paper if you would like to know more about fluid accumulation. So let's now leave preload and talk about contractility, which is a second determinant of stroke volume. Cardiac contractility is most often assessed at the bedside using echocardiography. Indices such as the LVEF, ejection fraction, using eyeballing or the Simpson's method, MAPC, tissue Doppler S prime, and global longitudinal strain are the most common parameters used to assess contractility. The dP/dt, which is the ratio of the pressure change in the ventricular cavity during isovolumetric contraction and available in some monitors, such as the PICO, may also be used. Afterload is the final determinant of stroke volume or cardiac output. Now, a common fallacy is that afterload is the same as total peripheral resistance. That is not true, although peripheral vascular resistance is often taken as a surrogate at the bedside. Remember, however, that measurement of peripheral vascular resistance requires cardiac output measurement. So afterload is the load against which the left ventricle must work to promote forward flow, so to promote an ejection of blood from the ventricle into the systemic circulation. And it is measured as the ventricular wall stress during systole. It is calculated as the pressure times the radius of the ventricle divided by 2 times the wall thickness. And although this may theoretically be possible, it is often not estimated at the bedside. You may also measure afterload on the right side of the circulation, but the same principles also apply. Increased peripheral vascular resistance, including the systemic vascular resistance and the pulmonary vascular resistance, may increase afterload. But again, these are difficult to measure in clinical practice, and often pulmonary vascular resistance measured, for example, using the pulmonary artery catheter or estimated using ultrasound, and the systemic vascular resistance estimated using cardiac output monitoring devices are used in clinical practice. Putting together all the concepts that we have talked about today, recall that both perfusion pressure, that is determined by the mean arterial pressure and the output pressure, as well as flow, that is determined by cardiac output, is required to maintain homeostasis in the critically ill. The adequacy of cardiac output may be assessed by the PCO2 gap, that is the difference between the arterial and the venous partial pressures of carbon dioxide. You may supplement this by other indices such as a lactate that assesses the balance between demand and consumption, and the SVO2 that assesses the difference or the balance between delivery and consumption. A fluid responsiveness test will tell you whether or not cardiac output will increase in response to a fluid challenge. And you want to do this because administering fluids when the cardiac output will not increase may be deleterious and lead to fluid accumulation syndrome. Now, in this paper by Professors Xavier Mounet and Jean-Louis Taboul, you will find an integration of all the concepts that I have talked about today. And now, in order to illustrate these concepts, Dr. Ahmed ZAHER will present a case study of Mr. John.
No questions so far as I've seen. You can please proceed, Dr.
Okay. We'll just start with the. I'm very sorry for my voice. I'm terribly sorry. It's always a pleasure to have to talk after Prof. Chew. I learned a lot, and I will always keep learning from you, Prof. Thank you so much. So basically, what I'm going to do in the case is we're going to make sure that we are implementing the fundamentals which Prof. Chew has kindly explained to us, and I will just go into my case in a minute. Start with the case. So basically, this is Mr. John presented to the emergency department with a 5-day history of lethargy, fatigue, nausea, and abdominal pain. We were called as an intensivist by the ED registrar. Please come and help us. Come and assess the patient for ICU. So in terms of his medical background, his background history is having type 2 diabetes mellitus, hypertension, and his medication history is on placebo as an insulin, long-acting insulin, a bit of Grill and bisoprolol as well. Apologies for my voice. Then after that, we did some clinical parameters on assessing him. In terms of assessment, he was self-ventilating, good air entry, no added preps or wheezes, warm and well perfused, very fill time is 3 seconds. He was a bit drowsy, P4, M5, P3. Abdomen is quite distended, tender, mainly around the epigastric area. And his initial parameters, heart rate of 125, blood pressure of 70/40, and a mean arterial pressure of 51, the temperature of 38.5, respiratory rate of 24, and a sense of 96. And then moving forward, we did an ECG for him. And just we wanted to make sure what's going on. And the ECG has shown that he's having sinus tachycardia, but of around 120 to 130. And then we did some bloods for him. And then the bloods we did some biochemistry, some coagulation, and we did for him a BBG. In terms of his biochemistry, he had a bit of AKI with a creatinine of 252, slightly dehydrated with a urea of 25, bilirubin was quite low, bilirubin was slightly elevated, 42, is 150, RP is 229. Going to his hematology, his hemoglobin was 125, platelets was 450, white blood cells is 25,000, now 18.6, 9 out of 1.2. On the biochemistry and hematology and coagulation, to summarize them, you would say that there is probably or possibly with element of an API with possible liver rearrangement as well. Going to his VPG, his acidotic, like giving a bicarb 16 with a lactate of 4.1. Remember, lactate here and something which has kindly explained us. It's an expression between your demand and your consumption. So it's not only about fluids here. After that, the patient was given by the ED department 500 bolus because we thought because of the highlight rate we need to give him fluids. Peritoneal intravenous antibiotics. We started them with mention and then we all know if there is an abdominal problem, I'll call our department. Surgical department and the surgical registrar said, okay, I'll come, but in the meantime, please read the patient and call your intensive. And then at that point, we ask ourselves a question: what? So what's happening? And why is it happening? And at that point, you need to ask yourself questions. So whenever you're seeing a patient who's hemodynamically compromised, whatever in your intensive care practice, you always ask yourself a question: what's happening, and why is it happening, and how? And at that point, we decided to take the patient to intensive care. In the meantime, we wanted to take the patient via the intensive care room. And then, when he reached to intensive care, we attached him to the monitor. We inserted a urinary catheter. We implemented an arterial line, bloods and blood pressures for the possibility of focus. We did for him a bedside echo. At that point, we did the back. And then also, what's happening and why it's happening. And always, while seeing patients in intensive care, remember it's a process. And it's a very dynamic process. We need to always practice and keep those what and why, and sometimes how. Going through his echoes, we are in a state of shock. So we need to ask ourselves a question: what type of shock are we having now? Tamponade? Unlikely with the clinical or the presentation. Hypovolemia? Possibly, but is it a hypovolemia or is it a relative? Tension pneumothorax? Unlikely in the context of the clinical picture and presentation. Cardiogenic shock? There's a possibility of that. And that's why we went for his for focus or the department. And you can see from the focus or the which we have shown that he's having a hyperdynamic ventricles, both in his parasternal long axis and short axis. As Prof Chew has kindly mentioned in the previous time, IVC/SVC is our fluid or volume status with them. You can see here that the IVC is significantly collapsing very well. The patient is either hypovolemic or relatively hypovolemic. So in the context of the clinical picture we have a possible provisional diagnosis. We have a possible it was having a relative hypovolemia, which is possibly secondary to a uterine-like picture, possibly secondary to a septic. And then the CT was done, and we have mentioned the CT has shown that this guy is having an acute pancreatitis, which is another cause of uterine-like picture. Remember, pancreatitis is a dry process. Frequently or often, this sterile process can be complicated easily to picture where it can be hypovolemia secondary to acute pancreatitis plus excessive blood focus, which could complicate the reason I'm saying that it will come through, it will not come with a 1% it will come with because, and it's always a spectrum. Remember, health is not an easy one way. Any questions? Oh, sorry. Carry on. Okay, I'll just carry on. Okay, so going back again, so which was his monitor? His monitor is so giving him the fluids and a bit of antibiotics. One that his heart rate is improving, hypothermic, but his blood pressure is still borderline. But you can see here that there's a swing in his arterial line with 100%. And then after that, we always need to understand what and why is this happening. And then after that, going to what's going on here. So we went there and we have seen that there is a problem with his blood pressure. So from there, we can determine with his swing, there's a problem with his volume. And at that point, you can measure your blood pressure variation. But in order to measure your stroke volume variation, you need to implement an advanced hemodynamic monitoring, which as Dr. has mentioned in our previous talk, or a thermodilution. In order to do your blood pressure variation, you need to understand the two values which you need to know: your pulse pressure max and your pulse pressure minimum. And volume is similar to need to be implemented an advanced hemodynamic monitoring. And this is an advanced hemodynamic monitoring. Remember, going through advanced hemodynamic monitoring, it's not available in every hospital in every part of the world. We have both calibrated and non-calibrated. We can show you here that the stroke volume variation is, and which is aligning with his arterial phase, which is showing the depth of wing, meaning that there is wiring a bit of a volume with a low blood pressure, with a blood pressure of 54, meaning that his bone or his plasma bone is depressed. You can tell here that his stroke volume is low, and his stroke volume or on the lower side, with low contractility, which is not aligning with the hyperdynamic circulation where you will be having a high cardiac output. Can come in one day.
So, Dr. Zahir, can I ask you a question? Is this was
Yes.
this patient intubated and mechanically ventilated at this stage?
Good question. No.
So he wasn't. So the stroke volume variation is 22%, which suggests that this patient may be maybe fluid responsive, and you see that variation that you correctly pointed out. So let me just ask the audience, what do you make of the stroke volume variation? What would you do in response to that? Would anybody like to answer?
So, ma'am, maybe I can answer
Yes,
it.
please.
So, ideally, ma'am, the patient should be sedated and ventilated. But there is suggestion in the literature that if the variation is to the tune of like 20%, even in a spontaneously breathing patient, that can be taken as a sign of fluid responsiveness in the right.
Yeah. Yeah, it could be, but yes, but and you identified very correctly. This patient is spontaneously breathing, and maybe because of the acidosis and pain and everything, they might be generating very negative intrathoracic pressures. So you would expect the stroke volume variation to be high. So I would not give fluids just because of this stroke volume variation. Although the echo does suggest that the patient does have intravascular hypovolemia because the chamber sizes were small, there was intraventricular obliteration and all those sorts of things. So, but the stroke volume variation in this situation where the patient is acidotic with the increase, decrease in, very negative intrathoracic pressures because of spontaneously breathing, you need to be very careful with the interpretation of not just the stroke volume variation, but also the pulse pressure variation. And I've put a paper in the chat about the limits of PPV, but it also applies to SVV. So very, very good comment, Dr. Bansal. Thanks, Ahmed. I think this was a really good illustration.
Will I carry on? Okay, I will carry on. Okay, and stick to what Dr. Johnson kindly mentioned. In order to have a stroke volume variation, you need to have these rules, these data stabilized, and they should be on controlled mode of mechanical ventilation. Tidal volume should be 8 mL per kg, and it's probably in a case of arrhythmia. The reason for that is just to make sure that your values are precise and there is no any sort of confounder which can affect the stroke volume variation. You can see here this is the Frank-Starling where you can responsible or not responsible for companies. And the second thing is and then the value is between 10 to 15. And the second thing is your variation also requires the same rule where you need to be sedated the volume of more than 8 mils. If you're having pulse pressure variation above 50, means that this patient is which is really interesting that you can do also a pulse pressure variation divided by volume variation. It's called the dynamic arterial resistance. Important because here it predicts your blood pressure response to fluid administration. Here it's a different parameter which reflects your blood pressure response to fluid administration. And this is very important though. The importance with this one is basically you can see there are two sides or there are two stages in your Frank-Starling is a bit of volume and the reason I'm saying that is that T part of your Frank-Starling, if you lose at this time, you will expect will be preload responsive. If you're giving at this stage, where is the of your Frank-Starling will be responsive. This is another, and in order to do that, as Prof has kindly explained, that is a test and it's difficult to be done. Especially if patients are having injuries and would be aligned around 45 degrees, and often that they should decrease their head and raise the leg of the bed to make sure that we measure response. Things also occlusion test and also it reflects in order to be positive, it will be more than 5% volume. And the volume challenge is easily can be advanced hemodynamic monitoring. If you increase your tidal volumes from 6 to 8 minutes G for you can see if is needed to be change in your hemodynamics, decreasing your blood pressure, mean arterial pressure, and increase in your heart rate means that this patient is on load responsibly part of point is according to and this is a mini fluid challenge where you can give the patient 100 minutes of fluid and see if it will cause any sort of change in your hemodynamics. And also response, you need more than 10% in your your hemodynamics. Okay, and always after you support, you give them fluid. We started, we give them, line therapy, and these are some of the clinical parameters we have lactate is still high. What and why here? And venous sats, 85%. There's a problem here. And also my CO2 4 mils. Some of the hemodynamic monitoring. Some of us would familiar with them. something like the global intestinal volume will give you an indication or an insight about the intestinal volume of your own body. Also, your extravascular lung water gives you an indication of your vascular, if you're having any sort of your pulmonary vascular permeability, which shows if there is any sort of leak. The last one is your cardiac function index, which is mainly a reflection of your cardiac function area. From these numbers, you can say not leaking that much, but there is an issue with your flow / your pump. X because of your cardiac function index, which is low, your and your and your CO2 gap. But on the other hand, you can argue that by saying your venous sats are quite high. This means that you're having an adequate patient, or you're having an adequate output. At that point, you need to decide what is the meaning of lactate physiology, and in the context of that, what do we need to remember? Lactate, Prof Shu has kindly explained to us the process. It's a process in its whole, and it's a balance between your demand and your consumption. And at that point, you need to think about it more thoroughly and just take it point. Remember that there are two types for your lactic acidosis or lactic acidemia. Either you're having increase in your oxygen demand or oxygen availability, meaning you're having reduced perfusion, such as patients with old arterial or patients who are having reduced arterial oxygen content, who are having anemia or carbon monoxide or hemoglobinemia. On the other hand, it should continue meaning contributing. And on the other hand, leading to something glycols, or something else, such as mitochondrial myopathy, where lactate is not completely processed well at the level of the mitochondria. And then after that, we did the same thing. We did another parameters, and the parameters is basically the same. We started with norepinephrine. At that point, the venous sat is still high. We need to know what's the meaning of venous sats. Venous sats means it's a function of the balance between your oxygenation delivery, or your oxygen delivery, and your oxygen delivery. So it's a balance between your delivery and consumption, not the demand and consumption, such as lactate. The global oxygen consumption can be measured by the difference in your arterial and your venous oxygen. Therefore, the SpO2 is a surrogate of your global oxygen consumption. Remember, we can get two values: your mixed venous sats or your mixed central venous sats. Your mixed venous sats is which you can get from your pulmonary artery. Central venous sats is something that you can get from your central line. And from there, we can talk about venous sats or venous or the central venous sats is around 75. And both of them are the reduced venous sat is therefore a feature of a balance between a relatively high oxygen consumption and relatively low oxygen delivery. Are some examples where you can have an increased venous sat, probably either in your consumption or in consumption. On the other hand, these are some examples where you have an increased venous sat. Your oxygen consumption is either high or your oxygen delivery. Some clinical tips to go through here. Remembering critically ill patients with sepsis, mitochondrial dysfunction can happen despite adequate oxygen delivery. Your mitochondria not function well. At that point, you have a problem with your oxygen extraction, meaning you're having a failure of your oxygen utilization. In such circumstances, your venous sats can be normal. Not only normal, well, elevated venous sat doesn't always exclude fluid responsiveness or ictus. Therefore, be very careful. In the later stages of sepsis, activated venous SATs may be associated with may be related to mitochondrial dysfunction, or actually, we're at very late stage of our sepsis where you're having a poor microbiome. You know, remember in cardiogenic shock, your venous SATs will be low. Remember what I said in the beginning or a one identity. Then moving forward, 16 hours are not still improving. And at that point, we wanted to know what's going on with this patient, what's going on with his cardiac function, what's going on with his his echo has shown poor biventricular function. He is in his left atrial pressure, right atrial pressure. Very poor biventricular function. In the context of someone who's having sex, possibly this patient are significantly assessed able of carbon dioxide. At that point, we can talk about the CO2 gap. And the CO2 gap is it's either a reduced CO2 clearance in the states of reduced cardiac output, increase or an increase in the CO2 production relative to an O2 or consumption. Remember, it reflects the lack of CO2. And some clinical tips about it. Apologies. An increase in your tissues, CO2 is by increasing your central venous elevated CO2, which is more than is targeting this value in particular, critically ill patient didn't show any improvement. Remember to use it as a useful surrogate of vaccination in combination clinical. Going there, you need to remember, you need to rely on your clinical examination. What are the signs of tissue hypoperfusion in someone who is relatively hypovolemic, secondary to sepsis? Is there any altered mental state? Is he having motile skin? Having oliguria? Is he tachycardic? At that point, we will go through the mottling score. And the mottling score is basically surrounded around your knees. And the reason it's knees is because the knees is the first area, is one of the most sensitive areas to mottling. And the reason is behind this is because the amount of subcutaneous fascia is minimal. You don't have any mottling. One, if it's from the knee, if it's extending to the superior area of your knee. It's two, if it's three, it's more, if it's extending to the thighs, extending to your groins, it's four. If it's severe mottling beyond the groin, it's fine. And remember, capillary is a very important surrogate of perfusion. There are many little of fluid prostration based on your and also comparing it also with lactate. Many research which we can see by the and calculate on importance of the value of and in order to conclude, I would like to always conclude with four messages. Please always ask what, how, why is this happening? Always keep asking yourself every now and then to make sure that you're not missing anything. Always ask your colleague for help if you need. Remember the importance or the crucial value of clinical examination, implementation of the right hemodynamic monitoring system. Have a CVP or any of them. Remember the crucial value of the balance between oxygen delivery and consumption, which is SATs, and the crucial value of the balance between oxygen delivery and demand, lactic. And the difference between your perfusion pressure and remember, the last thing, progress is impossible without change. Those who cannot change their minds cannot change anything. We're not here to change your minds, but we're here to help.
For that really excellent case, very illustrative. I thank you for doing it despite you being sick and just coming off night shift. I have put some papers on the in the chat. If you want to download them, please do that. And I just wanted to know, Dr. Bansal, do you have any questions you want to raise, or anyone from your audience?
Thank you so much, Dr. Zahir Ahmed. Really appreciate it. As ma'am said, you're not well, we can make out, and you did a night shift. Really appreciate that. Thank you very much. And a wonderful case, very illustrative. Thank you very much. So, ma'am, maybe I can just put up some points for general discussion. Everybody would be well off, and more educated after that, and it'll be one nice hearing from you. So, ma'am, one of the things is, when you put a patient who has LV dysfunction and is in pulmonary edema, you put him on the ventilator. So the positive pressure from the ventilator is supposed to aid the emptying of the left ventricle, because the transmural pressure decreases because it compresses the left ventricle and aids the emptying of
Correct.
the ventricle. But the aorta is also within the thoracic cavity, so the aorta should also get compressed. So the left ventricle ejection should not be aided logically.
Yes.
That is not the way it is. So
yes. That's an excellent question. We quite often look at the heart in isolated chambers. So one is the aortic, the compression in the aortic. How much of that pressure within gets transmitted to the aorta, we actually don't know. That's number one, because we know it's very difficult to measure afterload. Afterload, as in the wall stress, and the afterload, the whether or not there is a coupling between the ventricle and the aorta. And one of the methods that you can use to measure this is the PPV over SVV method that Dr. ZAHER presented. I don't use it clinically because I don't think it's so well validated, and I also don't measure coupling, although I do it in terms of research. The other thing that is probably more important that I see every single day, and probably you see every single day, is when you put your patients on positive pressure ventilation, especially in the context of ARDS, is the effects that it has on pulmonary vascular resistance. Because although the positive pressure ventilation will help the left heart unload, because it decreases the transmural pressure on the left heart, what it at the same time does is it increases the pulmonary vascular resistance beyond a certain limit. So what happens is when you have and this it's patchy across the lungs, you can't really predict this, but it will compress the intramural vessels within the alveoli, and because the surface area is decreased, the pulmonary vascular resistance goes up. So the resistance to venous return, number one, goes up, and the pulmonary vascular resistance also goes up. And then you will see that as a decrease in cardiac output. So all these forces, they kind of need to balance out each other. And when it actually happens is different from patient to patient. So this is a really important point. Thank you for bringing it up.
Thank you, ma'am. Thank you for the detailed answer. So just carrying this on forward, ma'am, you mentioned about the fluid challenge. And you said 4 ml per kg, and that is what is accepted. Though a lot of literature says 250 ml to 500 ml, but the number is 4 ml per kg to be precise. So why have you chosen this 4 ml per kg, ma'am, as a fluid bolus?
Okay, so if you look at the all of the studies that have been written on fluid challenge, it varies. It varies from 250 to 500, but over the years it has become less and less. And usually it's 4 mils a kilo is about 250 mils, so it's a very practical value to use. The thing that you need to remember about the fluid challenge is you need to give it quite quickly, right? And if you look at all the papers that have been published, the time that the fluid is infused over has been decreasing over the last 20 years. So the new consensus guidelines in shock and hemodynamic measurement that should be published within the next couple of months will recommend 4 mils per kilo over 15 to 30 minutes. And it's a lot more difficult than you think, because I don't know what your infusion pumps do, but our infusion pumps can only do a maximum of 999 milliliters per hour. I think you probably have the same, right?
Yes, ma'am, somewhat, but we don't always give it to the infusion pump, we just run it.
You just, okay. It's really hard to put it. I mean, okay, but let's say we use an infusion pump of 999 milliliters an hour, right? So that means it's the maximum you can put in is 250 milliliters in 15 minutes. And even if you have two people pressing the bags, it's really hard to do a fluid challenge.
Right.
Yeah.
So, ma'am, moving forward, now, when we look at the response to your fluid challenge, we have these parameters, but the most important clinical parameter one would think would be the change in the blood pressure, the rise in the blood pressure. But we don't always, use the blood pressure, and that is what literature says. Blood pressure may not always rise, despite the patient being fluid responsive and you giving an adequate fluid challenge or a fluid bolus. And this has to do with, I guess, baroreceptor reflexes and stuff like that. So could you please, elaborate on that?
Okay, so number one, you should never use the blood pressure to assess a fluid responsiveness. So with a fluid bolus or any of those tests, an expiratory, so you don't use pressure. And this is a common myth, right? And I think Ahmed brought this up in his case as well. You don't use the blood pressure to assess the effect of a fluid challenge, because the fluid and the flow, the pressure and the flow, they're uncoupled. So if you really want to assess fluid responsiveness, you need cardiac output monitoring, unfortunately. The only way you can do it without cardiac output monitoring is in an invasively ventilated patient with no spontaneous breaths. Then you can use a tidal volume challenge. So that's the only way you can do it. Otherwise, you need to measure cardiac output. There are new methods coming up where they use the pleth index, the index that you have on the SpO2 curve. It tells you about how good the curve is, that index. A change of 2.5% when you do an N-expiratory occlusion test will indicate fluid responsiveness. So they are the only things that you can do, the only ways that you can assess fluid responsiveness without cardiac output measurement. So don't use the pressure.
Thank you. So,
Ahmed,
you want to say something now?
no, I just wondered if Dr. Zaher had anything to add.
No, absolutely, I agree with you, Prof.
Yeah. So, ma'am, one of the parameters, hemodynamic parameters, is systemic vascular resistance. And when we are taught about shock in our early college days, medical students, you classify shock. One of the ways is SVR, high SVR, low SVR. Now, in practical use, we really don't use SVR. So what is the real use of SVR? Do we use it? Do we not use it? So how do we interpret SVR, or what is the clinical use of SVR in the ICU?
Okay, almost nothing. It's basically for confirmatory reasons. So SVR is often taken to be a surrogate for afterload. And in some ways it could be, but it's not the same, okay? The way I use it is, for example, if I have a patient that is very hypotensive, the diastolic blood pressure is low, and I just want to confirm that it's vasoplegia, then I use the SVR. It's a confirmatory thing. There is no algorithm that uses SVR for fluid responsiveness, for hemodynamic management. I have it because it helps fill in the picture. So the important takeaway is that SVR is not the same as afterload, which a lot of people assume that it is. With regard to resistance and vasoplegia, I rely more and more on the diastolic blood pressure. Now, the diastolic blood pressure we didn't talk so much about today, but it actually gives you a lot of information. So a diastolic blood pressure of less than 40 millimeters mercury in a patient that's not a severe arteriopath will tell you something about the vasomotor tone. So if you have a patient who is septic, the diastolic blood pressure is, or in this pancreatitis patient, diastolic blood pressure is low, then you need to suspect that the vasomotor tone is decreased. So patient is vasodilated. There is one exception to that rule. Number one, if the patient is very bradycardic, the diastolic blood pressure will be lower because there is a longer time for decay. If the patient is very tachycardic, like at the beginning of this case, the diastolic blood pressure may not be a really good indicator of vasoplegia because there is not enough time for decay. So you also need to interpret the diastolic blood pressure within the context of the heart rate. But in general, diastolic blood pressure less than 40 will suggest vasoplegia.
Thank you. So, ma'am, what kind of advice can you give to most of us, ma'am, who work in low and low middle income countries and ICUs about assessing fluid responsiveness and assessing tissue perfusion? We really don't have, most of our ICUs don't have advanced tools, ma'am. It's mainly clinical and maybe arterial line and a central line, and not even that much in many ICUs. So, what kind of can you tell us, ma'am, please?
Okay, number one, don't underestimate your clinical acumen, because doctors in low and middle income countries are really good clinicians because you see so much. You have this huge volume that the European doctors will never, ever, they cannot compete. Okay, so trust your clinical instincts. Look at the patient. Is the patient cold? Look at the mottling score. Is the patient edematous? Look at the JVP. Listen to the heart sounds. Listen to the lungs. And you also put this up. And I'm sorry for the black lines because I assume that you can still see the black lines. So do you see this?
Yeah, we can see the screen now.
Okay, so you see the lactate. You can use the lactate. Right? So lactate will tell you something about the balance between the demand and the consumption. Remember I said that? And then for lactate, you don't need a cardiac output measurement. And then if you take the difference between the, if you look at the SVO2, it will tell you the difference between consumption and delivery. So it will also tell you something about the adequacy of cardiac output. And then if you take the PAVCO2, that will tell you about whether or not the flow is enough for the body to wash out the carbon dioxide. So with these very simple methods, you can test the adequacy of your hemodynamic management without having a cardiac output measure and all of those fancy equipment that we have. All right. And for extravascular lung water, instead of using the PICO, you just use your lung ultrasound with B lines. You can use, I don't really believe in VEXAS, but I believe in the venous Dopplers. So if you're looking at your venous Dopplers and everything suggests that, you know, that there is congestion in the splanchnic system, then you would also know that your CVP, you know, if your CVP is high, IVC is dilated, and you have, you know, inverted SDs in your venous Dopplers, then you will know that you need to de-escalate your fluids. And this is without putting in any fancy cardiac output measurements.
Thank you so much. And ma'am, just a final question. Thank you so much for all the lovely and detailed answers. There's this entity called post-operative surge, ma'am. Post-operative surge. You know, patient comes out of the OT and he has varying degrees of organ dysfunction. Sometimes acute kidney injury commonly, and people push in fluids and stuff like that. The kidney gets more swollen and all that. And sometimes there's florid shock, mimicking septic shock. So can you tell us a little about this entity, ma'am? Post-operative surge mimicking septic shock, and people push in antibiotics and don't recognize it. And you know, this is, I think, an important entity, and maybe you can, you know, with all your expertise in this, please elaborate, ma'am.
Right, so septic shock occurs in about 2 to 3% of patients undergoing major abdominal surgery. And it usually occurs about day 3 to 7, and it's a huge problem. Infectious complications are the number 2, the second highest, second most important cause of complications postoperatively. So that's one thing. Number 2, it's very difficult to separate the effects of surgical trauma and that hyperinflammation from sepsis, because the CRPs are high. They will be febrile. You know, procalcitonin is not really that reliable, and procalcitonin is also very expensive. So there is no magic bullet to help us diagnose sepsis in a patient that has just undergone major surgery. However, there are clues. patients who have undergone prolonged surgery, patients at extremes of age, and if it's a contaminated surgery, emergency surgery, they're all risk factors for sepsis. So it's number one is vigilance. Number two, antibiotics and source control, absolutely important. That's a completely different lecture in itself. One of the reasons why patients develop acute kidney injury after surgery is because the fluid balance hasn't been adequately managed. They always drop their blood pressures during surgery, if nothing else due to the effects of anesthesia. But patients may be hypervolemic and hypovolemic at the same time. You know about the Bellamy curve, with the U-shaped relationship between volume and mortality and all those other outcomes. So there is no real way of assessing where you should be on that curve unless you measure fluid responsiveness. I think in an elective surgical patient, the RELIEVE study told us that, I don't know how you're practicing in India, but certainly in Europe, we were giving huge amounts of fluids to patients. The pendulum has swung the other way, and now we're giving too little fluids to patients. So we have about a 7% incidence of acute kidney injury, even after elective surgery. And the sweet spot is supposed to be, according to the RELIEVE trial, you aim for 1 to 2 liters positive fluid balance after elective major surgery. Now, after emergency laparotomy, it's a different question. The FLOW-ELA study, it's concluded its recruitment just last week. So within the next 6 months, you will have some answers from the FLOW-ELA study. I think perhaps, Ahmed, you were part of that study?
Which one?
The FLOW-ELA in emergency laparotomy?
No.
No? Okay.
I'm going for the finesse school, being intensive care.
Okay. So within the next 6 months, Dr. Bansal, I think there will be some results from that study, and then I can give you the answer.
Thanks so much, ma'am, for all your lovely answers, and I think it'll help everybody. And of course, we'll put this up on the YouTube channel, for all the global intensivist fellow students to see and learn from. Thank you so much, ma'am. Wonderful and really honored, ma'am. Thank you very much. Really an honor. And thank you, Dr. Ahmed. Thank you very much, sir. Really appreciate it, not being well and being on night call. Thank you very much. Dr. Ahmed, I would just like a word with you if you don't mind.
Again?
Yeah, I will just stop the recording and can I just talk to you for 1 minute?